Hi, Rahul. Good evening.
Hello,
How are
sir.
you?
Hello, good evening. I'm fine. How are you, sir?
Good. So, Rahul, you're outside today,
I just came back.
right?
I was outside, but I was not sure whether I would be able to make it or not. But
Yeah,
I just came back.
sure. Great. We want you to start. Always.
So, hi Rahul, it's Mukta. You're going to monitor the chat box again, right?
Kandarp
That
is,
Kandar
Kanda.
should be. Yeah, Kandar.
Okay. And are we going to put up the questions for the panelists? Because I know that we've got very tight 7 to 8 minutes. If there are questions, are we going to note them down? Or are we just going to try and answer them in the chat box?
Kandarp for you to answer.
Yes, sir. Ma'am, what happens is if someone asks a question, there is a Q&A section at the bottom of your screen, which you can see. So if
Yes.
anyone asks the question, I'll be referring the question to the relevant panelists.
Okay.
I
Okay.
mean, the relevant question to the panelist, which it is aimed at.
Okay. Fantastic. Thanks very much, Kandar. That's good to clarify. Thank you.
Yeah, sorry, I missed on that. I should have, messaged everybody on the chat, on the WhatsApp about the chat board. Normally I do that, but I forgot. I think I missed it. All right. Good evening, Bhavna.
Hi, good morning.
Right. Good morning.
Good evening, all of you.
Hi, Jagdish. How are you?
Good, and how are you?
Good.
So we will be live in 2 minutes.
Less than 2 minutes, I think. Yes.
Yeah, less than 2 minutes.
Roy's on Swiss time.
Not really.
I couldn't believe the trains are like 2:12, 2:14. All of you who work for the United Nations, you know that better than me. I hated that. You missed train by a second. Mukta, Monica is at University College London. She's from London.
Yes.
And I think you
I'm
have a
very
bio.
pleased to meet you, Professor Lakhanpal.
Lovely to meet you too.
We are streaming live now, sir.
Okay.
So we are live now, sir.
Okay.
Over to Rahul, sir, to start. So please unmute, sir.
Hello, everyone. I'm Rahul. I'm the director at Poornima Group and co-founder of Poornima University. And I'm an architect by qualification, but I've been into the university system from quite a long time now. My father started the university and the colleges way back in year 2000. And last year we shook hands with JSPH when I met Anil sir in Jaipur, following the conversation in Jodhpur. So it's been a great journey up till now. We have hosted a lot of webinars, and my entire team at Poornima University are used to host webinars, and I mean we go a lot of we go live on a lot of pages. Our webinars are seen by thousands of people, and I'm happy that we are continuing the webinar, the series of webinar. And I thank JSPH and Anil sir and Jagdish boss to partner with Poornima University for public health courses. And this year too, we are having a lot of inquiries for PhD and MPH students. And we are hopeful that we'll get a good number of students in years to come, so that we impart good amount of knowledge in healthcare for the healthcare professionals. Over to you, Anil sir.
Okay, thank you, Rahul. Thanks for the introduction, Rahul. And it's been a great journey for last year and a half working with Rahul at Poornima University. The Jodhpur School of Public Health is not a university. We are an academic supporting body which works with the universities. We recruit students, we design syllabus, we bring the faculty, and we promote public health in India and around the world. And we started with the Masters of Public Health at Poornima University last year. We are in Jodhpur for last 12 years. And on 2nd October, it will be our 12 years complete, conferring MPH degrees. So far, we've conferred around, I would say, as of yesterday, more than 500 MPH degrees, mostly to Indians, Afghanis, and Middle East students. And we hope to expand it more and more. This is just out of a passion. And I'd like to make a couple announcements, which I'm required by my organization and by lots of partners. We are not funded by any drug companies, tobacco companies, alcohol companies. We do not involve child labor. It's totally academic and a community service we do. And this is more for academic enhancement. So this is more to promote public health in the world. And with the current pandemic, I think it's very, very important such webinars continue. And one important thing which I like to bring up today is that with the webinar, one thing has definitely helped us and which will definitely help the nation, the India, is that we've enrolled more than 10 PhD students as of yesterday at Poornima University. And the webinars have promoted that. And I think that way, I think India will get more on frontline of public health research. And I think research is very much needed. And I'm very proud of that. And I'm very thankful to all of you who assembled here, donating your time. And this is your commitment. And I always say that this is the public health service we do. And it is a rent we pay to this planet where we belong, all of us. So to be very clear, this is just a commitment from all of these people in the panel and people who have organized this. So thank you very much. And I'll give it over to Jagdish, who's my colleague. And we worked together for last 20 years, started working with the AIDS pandemic, and now we are in COVID-19. Over to you, Jagdish, to introduce Indic-Chain and take it forward.
Thank you, Anil. And thanks for the introduction. Yeah, it's really great to be part of this series because it's very close to us. We have been in the journey in the AIDS pandemic, and now we are going through this raging pandemic, COVID, and there are a lot of parallels, a lot of stigma issues, and a lot of other things that we can learn from. Dr. Prasada Rao is here, who was mentoring us back then, and he's there with us today. That's great to see. I run a company called Mobiloid Group of Companies, and we have an initiative of Indic-Chain, which is a learning records management platform. That's a digital skills wallet that we are promoting in India. So that's linked to the Skills India program, and we are trying to do our bit into the digital health as a partner to the Poornima University and the Jodhpur School of Public Health. Thank you. Over to Roy or Anil. Roy. Right, please. Thank you.
Good evening, everyone. So hi from the wonderful city of Bangkok, Thailand, where it's 8:05 p.m. on a hot fall day, I should say. And I will be one of your two co-moderators. I'm with the Population Fund of the United Nations, and I'm here in my personal capacity this evening. It's a pleasure to be here with you all. And let me now transition to my co-moderator, Dr. Mukta Sharma. Mukta, over to you.
Thank you very much, Roy. Hello, everybody. Delighted to be here with you. My name is Mukta Sharma, and I work for the World Health Organization. I'm based in Delhi, in the epicenter of the epidemic. I work across the region, and my core areas of work are HIV, tuberculosis, STIs, and hepatitis. But of course, COVID has now taken over everything, and it continues to become a really important part of our work. So I'm delighted to be here today with Roy, who is a friend. And you see, we're even wearing the same color T-shirts. So what we're going to do is we're going to split up the work between us. And I'm going to start with the first few speakers. I know that we have very, very limited time for all of the speakers. And I just want to let you know that I am a very, very hard taskmaster when it comes to time. I will let you know 1 minute before. If you will be so kind as to be on time, that allows people to ask questions. So if you want to keep yourself on mute, we love audience participation. Please make sure that you type your questions in the chat box, and my colleague Kandar will be sharing these with the panelists for answers. So without further ado, I'd like to start with our first speaker, Dr. Jonathan Quick. Jono, as he's also known, is an international health leader, and he is on a mission to protect humanity from deadly pandemics and infectious disease outbreaks. He's written a wonderful book, which is called The End of Epidemics. This is looking at more than 100 years of experience with epidemics, learning from them and seeing what we can do about them. He heads the pandemic preparedness work at Rockefeller. He's also an adjunct professor at Duke. And I could go on and on and on and tell you about the wonderful work that he's done, but he has a hard stop and he needs to leave early. So I'm not going to say that much more about him by way of introduction. Jono, will you talk to us about what surprised you about this epidemic? What have been the good surprises? What have been the bad surprises? And you have 7 minutes, so over to you.
Many thanks, Mukta Sharma. Nice to see a fellow WHO person, and congratulations to Anil, Jagdish, Roy, and the whole team for, again, another great lineup. So let me move very quickly in to just give you the highlights of some of the surprises. So COVID-19's been just what we feared, full of surprises. So what I'd like to talk about is 3 areas where we have seen some great encouraging surprises, but also some very challenging surprises. And I think these can help us think about how to better prepare in the future. So on the science side, it has been absolutely stunning. I don't think most of us realize what a dramatic change we're going through in the whole testing field. We have been sort of linked to a lab-based testing, which involves big machines, reagents. Some of these lab machines are tens of thousands of parts. They're absolutely essential for highly accurate testing, but point of care, we know rapid response, rapid action. And in this country, we're on the move from, in the US, 1 million tests a week to, by January, well over 30 million tests a week because of the new technologies. Biosensor dogs that can actually pick up coronavirus, we know from other diseases, are being tested and deployed. They could potentially screen 200 passengers an hour. And stunning, absolutely stunning, 8 months, just 8 months into the pandemic, to have 16 vaccines either approved for limited use, some shakiness there, but at least in clinical trials. So some stunning scientific breakthroughs. But hey, 9 months into it, we're still trying to get a grip on some of the basics. And I won't go through each of these. I mean, but these are the kinds of things where we need the answers to these questions. And we're moving slower than we'd like to in resolving some of the questions. And so I think we need to reflect on, are we, for some of these clinical questions, do we have the mechanisms to move as quickly as we need to? On communications, that's when the only tool that we have really to contain it, and the tool that has contained it so far is human behavior affecting what we do, you know, where we go, whether we protect ourselves with face masks and distancing and hand washing. And the principles of pandemic communication are clear. And we had now the fact checker groups have come together with some good advice on identifying fake news. But the stunning surprise is the overwhelming misinformation and disinformation, and the coming together of the sort of the conspiracy communities that have been very active in the political area and all, with the anti-vax movement, and several different threads of organizations and tools that are spreading misinformation and disinformation. And there's some absolutely fascinating innovations that are happening with the social media platforms to put in viral restrainers to bring up correct information on the screen next to incorrect information, and to do a variety of different things, so that there has been some dramatic efforts forward. But the reality is that we may end up in many parts of the world having safe, effective vaccines against coronavirus, but they're not getting deployed and used the way they should. And in some places, the basis for distrust of vaccines, and I'm hoping you'll hear from Heidi Larson next week on this, but in some places it has to do with this long-standing vaccine autism myth that was disproven within months and over the first few years after it was first hatched in 1998. But we're still fighting that problem. But then if you look in different countries, you'll see that issues about safety come out of personal local experience with vaccines. So the whole communication field is where we've had some really good news, but some really bad news. The other thing that's been really fascinating, and that is that there have been a lot of pandemic projections based on the 1918 influenza and all. And on the left there is a projection that 5 years ago, in the aftermath of some of the bird flu scares in the mid 2000s, and the H1N1 flu in 2009, and then Ebola, which never would have gone global, but certainly set global Twitter records because of the horror factor. Bill Gates and a number of other people, but got very involved in looking at pandemic risks. And so this is what was deemed to be a relatively conservative modeling of what would happen, and they just took notionally an outbreak out of West Africa. What would that look like in 100 days? 770,000 deaths. That's like a really bad flu worldwide. On a seasonal flu can hit 750,000 on a really bad year worldwide. And that's 100 days. 200 days, it would be at 33 million deaths. That was what the scenario showed would happen. And what's actually happened here with coronavirus is we're at around day 245. You guys had a good calendar check to double check that. But this is today's total. So it is absolutely stunning in the sense that the deaths have been fewer than predicted, which is great. But the unpleasant surprise is that the effects on economies and all of the knock-on effects on livelihoods, on suicide rates, on domestic violence, on food supply, on the gains that we've had in the area of health, and the knock-on effect on health systems is in terms of dissuading, disrupting immunization. We have 80 million children at risk of not getting their childhood immunization because of this. Those knock-on effects have been far worse than the pandemic modelers and predictors had anticipated. And the other thing is, I may have missed this in my deep dive on the last century, but I don't remember seeing any scenarios that looked at the entirety of the globe. I actually remember some of the analyses predicting much less impact in low and middle income countries because of lots of becauses, but they just hadn't thought it through. And it's a little bit analogous to how West Africa got blindsided by Ebola. Before the 2014 outbreak, there had been 22 previous outbreaks in Africa, all of them under 1,000 cases, many fewer deaths. And the Oxbridge biotech folks, and some of you may have heard me say this before, just 5 months before the Ebola outbreak, said that Ebola was a dead-end event because it would go so rapidly and kill so quickly, it wouldn't spread. They never did any scenario planning. What happened if you had a funeral in a rural part of one country and somebody got on a plane and went to an overflowing slum in another country, as happened between Guinea and Liberia? We have not done the scenario planning. And so each country was sort of inventing their own plan. And so I think my hope is that recognizing where we got it right and we're prepared and have been pleasantly surprised. I think for many of us, if you had told us a year ago that we would have a total paradigm shift in the testing field, or that we would have 16 vaccines in human trials 8 months into this, I think a lot of people would say, I can't imagine that. So I think we really need to take a look at how we can better anticipate and prepare for the inevitable surprises of the next pandemics. Thank you. And Mukta, back to you. You haven't rung your bell, so hopefully I did okay on time.
Thank you very much, Jonathan. You were quick. Thank you. That was wonderful. This has really got me thinking about the surprises. And for me, one of the biggest surprises when I compare the COVID epidemic to the flu epidemic of 1918 is that we've had so few deaths in India. If you look at where the majority of the deaths were in the flu epidemic in 1918, they were in India, but yet we've not seen that here. Anyway, I'm not seeing any questions for you, Jonathan. So I would just like to thank you very much for this wonderful presentation. And now I'll hand back over to my co-moderator, Roy, for our next speaker. Thank you again, Jonathan. Much appreciated.
Thank you. Thank you. Appreciate it.
Thank you. Thank you all so much for that, Jonathan. Now from the big picture to a very personal story. This section is called When Worlds Collide, the Professional and the Personal. And we've been featuring in these episodes stories of people, including healthcare providers on the front lines, who have actually experienced COVID-19 themselves. We had 2 fantastic speakers when we did the episode several weeks ago, and we have yet another story with us this afternoon, evening, morning, and that is Dr. Kapurchand Chaudhary, who has been working in the field of public health, medicine, and surgery for the last 45 years. Actually, I'm told 45 years plus. And Dr. Chaudhary is a surgeon of oncology. He has been at several prestigious institutes in Rajasthan, and he is currently the head of the surgery department at the Pacific Institute in Udaipur. Dr. Chaudhary, without any further ado, let me hand it over to you for your truly personal story. Over to you, sir.
You're mute, sir. Dr. Chaudhary, you're on mute.
Are you listening me?
Yes, please go ahead.
I'm working as a professor of surgery at Pacific Institute of Medical Sciences, Udaipur at present. I had deep interest in coronavirus, and I'm studying this, though it was not my original subject. I am a surgeon, but still I had a lot of reading about this subject. Now, in fact, I had an experience myself. I have encountered with the coronavirus. In fact, my 31-year-old son was tested corona positive, and next day I was having fever, dry cough, and the breathing difficulty on exertion. So it is stuck in my mind. It could be a corona. I have started having a pulse oximeter reading, which were wavering around 93 to 94%. But next day, this came down to 92%. And I was tested positive. So when it was tested positive, my heart started to spin in worry. I was distressed and had many anxious thoughts in my mind. I was bought with the negativity and the doubts. The dread of that night remained etched in my memory. Of course, a doctor is a bad patient with a lots of ifs and buts. I was not exception. I started thinking about all possible worst complications of corona, including the effects of hypoxia on the brain and liver and the kidney, the lung fibrosis, scar formation, ERDS, and so on. That was the worst nightmare I have ever faced. Next day, I was admitted to the AIIMS Jodhpur in a COVID ICU ward and was put on nasal oxygen. It started with the dexamethasone, low molecular weight heparin, vitamin C, cough syrup, etc. Medical and paramedical staff behavior were very kind and sympathetic to all the admitted patients, including serious one. They were administering medicine. Next day, my pulse oximeter reading came to around 97%. And I was off the oxygen for that time being. Next day, I was sustained. It was without oxygen. This pulse oximeter reading was 95 to 96%. But thing has happened that I was tested with the X-ray chest, which has shown the haziness at the both costophonic angle. Again, I was worried about lung infection and consequent the fibrosis and the complications. Now, what kept me strong when the world around me was crumbling? My spiritual practice, because I'm practicing yoga, meditation, and the morning walk daily. So from last couple of years, so my spiritual practice and my positive attitudes helped me to overcome this crisis. On the hospital bed itself, I started practicing meditations, deep breathing exercises, though at the slow pace. Initially, I could not give more exertion because this will affect my breathing problems. Now, this has helped me to bring harmony between my body, mind, and the spirit, and reduce my stress and anxiety to a great extent in 2-3 days. But it made me calmer, peaceful, and energetic. Now, what I have done now is I have started lying in a prone position as suggested by some doctors, which has helped me to overcome my respiratory distress. My oxygen saturation was near 96-97% without oxygen support. I was having no major symptoms. And after 3 days, when my X-ray was taken, X-ray chest was taken, it was normal, and it gave me a great relief. I was shifted to the special non-ICU ward and was kept under observation with some same protocol. You will be curious to know how I passed my time during that period because I was isolated. There was nobody around me. When you are not allowed to meet the families and friends, so it gives you a lot of trouble thinking. But how I passed my time is, I had a legend classic song collections in a portable way. So I was listening to the music of my choice. I was listening to the songs of my choice. I was reading few books, couple of books. And I have started reading the books which I was reading during my childhood, like Nandan Chanda Mama and Panchantatra Ki Kahaniya and 100 Arabian Nights and so on. And that has helped me to overcome the loneliness. I've started doing some drawing also, which I have been missing during my medical careers. So these were my best companion. And because of that, these companion, I could able to live alone with peace and harmony. On the 8th day, my all parameters were normal. I had undergone a COVID test, which luckily was negative. So I was discharged from the hospital.
We have to wrap soon, Dr. Chaudhary.
Yeah.
For a minute, please. Thank you.
Should I continue?
Yes, if you can just wrap up, please, in 1 minute. Thank you.
Okay, I will wrap up it. What I have learned, the key message, what Corona has taught me is I have learned the importance, life is more important than money. Keep yourself physically fit by regular morning walk, aerobic exercises and other things. And follow the guideline which has been advocated by the WHO and other things. Thank you very much.
Thank you so much, Dr. Chaudhary, and I'm sorry for having to interrupt you. It sounds like, first of all, I should say, thank God that you are safe and sound and that you're here with us this afternoon. And I think your experience is quite similar to others that have been shared with us, that this really shows you what is the most important things in life. And from that, I think it's a perfect segue to our next speaker. And for that, it's back to you, Mukta. Thank you.
Thank you very much. Dr. Kapoor, there is a question for you in the chat box, which is asking how your family coped with it. And I think if you would just like to type that answer in, that would be really helpful. So we heard a little bit about the physical experience of Dr. Kapoor, but also how he coped with it. This is a nice segue into the next area that we want to think of, and that is the mental health aspects of COVID. Many of you would have heard stories about grief, people's lack of closure, families not being able to say goodbye to each other, post-traumatic stress disorder, as well as depression. So there is no better person to speak to us about this than an expert in mental health. Our next speaker is Dr. Naresh Nebhinani. So Dr. Naresh Nebinani is a psychiatrist. He's an additional professor of psychiatry at the All India Institute of Medical Sciences in Jodhpur. But he's not just a psychiatrist, he's also trained in yoga and naturopathy. He's widely published with over 150 publications to his name. So Dr. Naresh Nebinani, we invite you to talk to us a little bit about the mental health aspects of COVID. What are you seeing in the real world now? And can you give us some tips in terms of what are the key things one needs to be bearing in mind when it comes to mental health? Over to you, Dr. Nebinani.
Thank you very much, one and all. And it's my pleasure and privilege to talk about mental health issues during this pandemic. Hope I'm audible and my slides are also visible. As we all know.
Yes, you are.
Yeah, thanks a lot. If we see the World Health Organization definition for mental health, then one should realize his or her own abilities. One should be able to cope the normal stresses of life. One should be able to work productively, and one should be able to contribute to this community. So that's what we have heard now, and definitely we will contribute more through this. If we see the COVID-19 pandemic, then definitely the problems of mental health have increased dramatically at all the parts of the world. These are the new problems as well as the pre-existing mental health problem which were stable, those have increased because people are not able to get proper supplies, proper healthcare services, and this COVID has increased stress for all of us, including the people who are quarantined or isolated, including we heard the previous speaker, Dr. Chaudhary has also shared the experience. And on the top, it has a delayed risk of mental and physical health problem. Because of that, also mental health problems have gone to increase. If we see the another phase, our own people who already have the mental health problems, their risk for COVID-19 is also dramatically more than the other general population. And again, their services are also pretty less in the entire world. Dear friends who all are at risk for mental illness, then again the people with COVID-19 or presumptive diagnosis for COVID, their family, healthcare providers, we all, other corona warriors, all these students, including children of schools, general public, and at large, all of us sitting on the globe have increased risk of mental illness because of this pandemic. What are the factors? Yes, there are illness-related factors, the fear associated with illness, social disconnect, economic crisis, and again, healthcare service-related factors, and again, specific factors to quarantine and isolation, as we heard. And on the top is the stigma, discrimination, loss of status, and again, loss of loved one. This all is increasing our risk for mental illness. If we see, yes, during the COVID-19, this presumptive diagnosis, people develop anxiety, panic, depressive reaction. And as well, the people who are diagnosed, they also have an intense reaction because of various reasons, including discrimination. They develop commonly depressive reaction, anxiety symptom, adjustment reaction, and many times post-traumatic stress reaction. And if we see the commonly in the globe for the people as well as healthcare providers, they have subsyndromal mental health problems. In general, we see meta-analysis report, 1/4 or 1/3 of the general population who is suffering from COVID-19, they have anxiety and depressive reaction, their stress is increased. And on the top, if we see the healthcare providers, their reactions are also intense and commonly anxiety and depressive reaction. But here various individual and structural variables are moderating the risk. That's why few people are healthy, few are developing mental health problems. So we'll work on that. But on the top, behavioral addiction is on rise. All of us are more on screens, including now, but this is for productive work. But the world is seeing digital screen more commonly. That's why the problems of methodological internet use is going to be there more. Yes, in the globe, including in India, we have seen suicide has increased dramatically because it's a perfect storm. Economic crisis, social isolations, barriers to mental health treatment, various illness-related factors, various quarantine-related factors, various healthy behavior which we were doing before COVID, we are not able to do that commonly. The risk group are, yes, children and adolescents because of various issues, including school closure and losing their family and dears. Geriatric group, yes, we are seeing on the globe, they have the most adversities because more common morbidities as well as mortality. And yes, this group needs more support from all of us. And yes, healthcare providers in all the streams and all the parts of the globe, they are also highly affected group because of various institutional factors as well as COVID-related risks, because since they are dealing with the patients, the risk of COVID is much higher. So we need to address their personal fear annoyances to increase their team effectiveness, improve their peer support, and also improve the non-judgmental environment to deal with their mental health issues. And there are a couple of leaflets most of institutions have shared. I'll also share in the group. We have also derived. So I'll now focus on the last slide, which is the most important for all of us on the globe, including healthcare providers. We need to have a lot of the strategies were shared just before me by Dr. Chaudhary. I'm thankful to him as well as the organizer to giving this patient of the presentation. We need to have positive attitude to know that the circle of control, what can I do? And circle of concern, what I can't do, but it's beyond my control, but I'm concerning. We need to have positive thinking, positive emotions with their own strategies. Definitely, we need to have a healthy lifestyle to prevent physical and mental health problems. Good exercises, good relaxation, yoga, meditation, proper sleep, proper nutrition, and so on. And again, to remove all the improper healthy styles which are not healthy. To improve connectedness with the self, with our near dears, with our colleagues, with all on the globe, we can be connected emotionally. Please be, because it's the most important time to reconnect. As Sir has mentioned several strategies. We need to learn proper appraisal, because unfortunately the appraisal is faulty, and that's why we see the problem just like a mountain, a big one. We see our support very small while it is very big. So proper appraisal for the problem, proper appraisal for our support system. On that of active adaptive coping is most important, and one of that is problem solving skill and approach. There's a problem, yes, we need to have solutions in one or other fashion. We need to learn more adaptive skills, just like a problem solving skill. We need to have general prayer. One of my favorite is serenity prayer. God, give me serenity to accept the things which I can't change. Give me strength to do the things where I can change, and most importantly, give me wisdom to differentiate both. Have our own spiritual practice, learn as altruism, more empathetic approach towards the world. We need to have more mental health literacy, awareness about that, and also strategies to handle the stigma. That is a bad reason people don't seek the support. We need to have more and more psychological first aid. With that, we can look better about the people who are suffering with some problems. We can link them and we can connect with them, or connect with the proper authorities. So look, listen, and link with them. Definitely we need to work to build psychological immunity, because dear friends, this is the time when we all are talking about physical immunity. It's very important, but yes, on the top, psychological immunity is the people who are having more peace, more strength, they are performing much better. Despite going into the COVID picture, they are putting as a better flag for all of us. I'm available for all of the questions and comments. And yes, the mental health issues are going to be there for a couple of years. That's why the concern by the organizer and everyone, it's very important, because if we deal with this now, we are having better future for entire life. Thanks a lot for patient listening. I'm available for all type of questions. Thank you to the chairperson, Gupta ma'am. Over to you.
Thank you very much, Dr. Nebinani. That was very, very useful. I can see there's a question in the chat box related to stigma. If you'd want to take a look at that, that'd be great. So I'd like to move on to our next speaker, Professor Monica Lakhanpol. Professor Lakhanpol is an internationally recognized academic working at the Great Ormond Institute of Child Health within the University College London. She's a champion for child health. She's been working in South Asia, in Nepal, in India, and Indonesia, Africa, and she's been working in a wide range of areas looking at pollution and WASH and childhood nutrition. And today, Professor Lakhanpol, we want to hear from you. What is your assessment of the impact COVID has had on child health? And within that impact, as you see it, how will it change the way we look at child health going forward? What's the post-COVID focus for child health and priorities that we'd like to see post-COVID for child health? So over to you, Professor Lakhanpol. Thank you.
Thank you very much, and thank you for the kind introduction. And namaste to everybody. And it's about 3 o'clock in the afternoon here, so it must be late in the evening in India. Just to give you a little bit of context, so I'm a pediatrician. I'm a practicing pediatrician, so I have been seeing children who have been living through the COVID crisis. I also have a family of my own who I have seen firsthand some of the impact of COVID on them. And today, I'm not sure if many of you know, but the Sustainable Development Goals, the 17 Sustainable Development Goals, were actually adopted on the 25th of September. And I think that's why it's quite wonderful that we're having this actual conference today. So what about children? I think the children in the current climate are actually going through a major crisis. a lot of the information that we're receiving has been talking about the fact that children are not getting COVID, that then their symptoms are much less, that in some degree we don't have to worry about them so much. There's also the news that comes out with talking about how young people are actually being transferers of the illness and having impact on the elderly, making them feel quite guilty in this whole process as well. But yet the impact on these children are going to be huge. We have a whole generation of children who are being born through this time, who are growing up through this time, who are being educated through this time, who actually need to be the adults of the future. And yet they are missing out on so many vital ingredients that make them into good human beings. So just to recap on a few of those in the short time that we have and some of the impacts it has had. Well, if we think of children growing up into adulthood, there are a few critical windows. You've all probably heard about the critical windows when we can influence children's health. That starts antenatally with the mother, then going through to the early years, and then going through to adolescence. And there's not one part of that life course that hasn't been affected by COVID. From the mother's perspective, we've all been fighting with the SDGs to try and make mothers more nutritious, to give them a healthy diet so that their children are healthy. Unfortunately, through the COVID, the mothers don't have enough time for themselves. They don't have enough time to look after themselves. They have even less access to good nutrition than they had. They take on a huge amount of stress from the family, keeping the work going, keeping their livelihoods going. And naturally, this can have an impact on the children and the babies that they are going to give birth to tomorrow. Once the child's born, then we have children who are growing up through these early years into the young adulthood. And what are the key areas that they're touched on? Physical health, mental health, we've just heard a bit about, and I'll touch a bit more about on that, and education. So in all of those children, there are going to be subsections of society who are even more marginalized and who have even more problems than the others. And we mustn't forget that all children are affected, but there are some groups we must target more effectively. Children in poverty, those with disabilities, children such as those in refugee camps or migrants. And there is a gender difference. We know there's a gender difference in the impact this is having on girls and boys. I'm not saying that boys and girls aren't both impacted, but they may be impacted in different ways, and we could touch on that if we need to. So for physical health, some of the areas we may be considering are, we talked about physical exercise, the need to have physical exercise. Well, if you're a child locked in a house due to the lockdown rules, or your parents are ill and your carers are ill, where do you get that physical exercise from? So we are going to see a generation of children whose physical exercise has been impacted. This then leads to increased obesity, increased diabetes, increased heart problems. We then think of nutrition. Nutrition is related to vitamin D deficiency, iron deficiency. If you're locked down and you cannot get out of your household, how are you going to have the vitamin D that you need? Well, that then means you have the risk of brittle bones, you have rickets, and all the other consequences we know that are huge around vitamin D. Further to that, we know that the child's development is crucial at this young age. And how are people being accessed? How are children being accessed by frontline health workers to support child development, speech development, particularly, again, those with disabilities? So for example, children with Down syndrome. If they have Down syndrome, again, are they getting the support they need? Are they getting the education they need? The stimulation they would normally use. So again, we have a whole group of children who should be developing through this critical stage of their life and missing out of these key interventions. Mental health we've talked about, and we've talked about how increased depression, increased anxiety, and the economic crisis is having on young people. They don't know what their future is going to be like. They don't know if they're going to have jobs. They don't even know if their education is going to match with anybody else's education. And we don't have access to treatments either for them. So we talked about the digital divide. On some ways, digital access is so important to give education to children. On some ways, it is terrible because children are being bullied through cyberbullying and other ways. So how can we balance these two benefits and risks, really, of that? There's many more things that I could talk to you about, but just very quickly running through some of them, we've talked about prenatal care. School meals, I think, is something we should consider. Children were given school meals as a way of helping their nutrition. That safety net has now been removed for many children. We have no idea the consequence this is going to have on kids. So what do we do for the future? The future, I think, is starting with the parents within the household. How can they give their children and build resilience for their children? How can they listen to their children, their fears about seeing people dying around them? We've never seen children having to go through that before. How can families support access to healthcare? As public health experts, as we're all sitting here, we have a real, we're basically the ones who are at the forefront of trying to change child health for the future. We must access these children either with mobile units or some other mechanisms that we can have. We need to reach out to them and actually start developing positive strategies together and public health strategies before we actually miss this critical stage of these children's lives. So we need to come together globally. Collectively, globally, we need to come together. The time for observation has gone, and the time for action is needed if we're going to go through the recovery phase going forward. Thank you.
Thank you very much, Professor Lakhan Paul. One of the issues we're seeing in our region is the lack of immunization. And we're really struggling with kids being born not accessing any immunization. Hepatitis B, which is really a big issue in our region, we're seeing at least 500,000 kids who are not going to be accessing immunization. So if I was to say, what would be one or two top priorities for India? Because today this webinar is about India. What do you think we should be focusing on to really catch up on some of these big losses that the children in India have had to face because of COVID? I know this wasn't a planned question, but I'm genuinely curious to hear your answer. Please, if you've got a minute on that.
No problem. And choosing three priorities is always tricky, but one area I think is you've targeted on the vaccinations. If we don't vaccinate our children, they're going to have secondary consequences. So we have the COVID, but we have secondary consequences. So children will pick up other infections which they wouldn't normally pick up. So that's a huge problem. How do we do that? We need to go back to the days of accessing children. We need to reach out to them. We have to have mobile units where we enter into the communities and we go and find the children, do mass immunization. It's always a tricky thing to discuss, but if we don't, we are going to lose the children of the future. The other aspect that I think is, we've talked about mental health. We are going to have a group of children who are going to have huge mental health problems for the future. This is going to cause consequences, behavior consequences, just socialization consequences. How are they going to become adults if they're disturbed children? And mental health in India, I know, has not been a high priority. We're already fighting for child mental health services so hard just without COVID. And if we don't ramp that up soon, we're going to have a society for the future that is going to be damaged. And the third, we can't take away nutrition. We have vitamins. I've talked about iron deficiency. I've talked about vitamin D deficiency, vitamin supplements. So the child health program I know in India is strong, but we need to now actually give more attention to that. I know the government in India has talked about the convergence plans, the Poshan mission, but actually we need to double our efforts or not triple our efforts to actually do that. The reason being, it's not just about nutrition, it's about those secondary consequences of children who will have long-term problems with chronic diseases as they grow if we don't do that now.
Thank you very much. That was so clear and so useful. So I think that, the three priorities that we've talked about for India are also really relevant for our entire region. So thank you. I feel extremely privileged to have heard you speak. And now I'd like to hand over back to Roy for carrying on. Over to you, Roy.
Thank you so much, Mukta, and thank you, Dr. Lakhan Paul. That was, pretty fascinating and sobering. And actually staying with the focus on India, our next speaker is someone who needs no introduction. He is a legend as well in his own lifetime. And I'm, proud to say that he's also a friend of mine. And that is Prasada Rao. He has worn so many hats across his career. I don't know where to start, but among them, he was the health secretary. He was in charge of the National AIDS Control Organization. And he was, of course, the regional director for the the UN AIDS Regional Asia Pacific Office. After that, he was the Secretary General Special Envoy for HIV and AIDS in the Asia Pacific. So, Prasada, the question to you is something in a way similar to what we spoke about when we were last interacting on these webinars, but it's, I think, taken on even more of an urgency, because in that time, India has now come up the, shall we say, COVID-19 rankings to being one of the top 3 hotspots. And that is, why has prevention failed so far in this huge country to control COVID-19?
Thank you, Roy, and good evening, everyone. And yeah, thanks for your introduction. Second time you are doing, I think we are meeting here on this. Well, I think I would like to talk a little bit on why prevention has failed in India to control the COVID epidemic. I would definitely, it's a strong statement to say, but I venture to say that because I've been watching the epidemic literally slipping away through our fingers around, say, the May, June. That was the period of time. Normally, when we look at prevention and treatment in any epidemic, the treatment is something which is very visible and you know, it is very impactful to start with. So I think generally it always takes the leading role. And same thing happened. I think our initial response to COVID epidemic has been entirely biomedical. We looked at reported cases and then how many of them can be treated and what can be done in the hospitals. I mean, that's extremely important. But in the process, somehow or the other, prevention has taken a back seat. Whereas it is prevention which is the key to control any epidemic. Now, we started with enforcement of travel restrictions, quarantining people, and then came the prolonged lockdown, which is almost continued for about 2 months, 1 month, 3 weeks or something like that. And that would have given a great opportunity for us to set our house in order on prevention and to start some of the public health measures which are needed to see that prevention is properly taken care of. But somehow or the other, the entire effort at the time of government was to see how strictly we can enforce that lockdown with the help of police, with the help of law and order machinery. So it became more like an exercise in controlling the movement of people than controlling the epidemic. I mean, the priorities were somewhere else. And then the sheer unpredictability of the spread is also contributed to that. I would say that it entirely is up to the government, but nobody could really figure out where the epidemic was going. But had we adopted some very important public health measures, which are always necessary to control an epidemic, probably we would have done better. One is, for example, the entire issue of serosurveillance. In any epidemic, the data and information are of the utmost important, utmost priority. Here, the ICMR started a serosurveillance in important metropolitan cities. But when the results came, they didn't want to announce it. Because by that time, already 10 to 20% of the people in the cities are already carrying the COVID infection. Of course, majority of them were asymptomatic. They wouldn't have really resulted in active COVID cases. But I think somehow or the other, there is a hesitation to sort of take the people into confidence, saying that, look, this is the situation there. And this entire information went under the wraps. It never came out. Even now, I think we don't have the data available as to the prevalence levels of COVID in the metropolitan cities of a survey which was done in May. And today it is no more relevant. It may be twice, 3 times more. So it is no more relevant, but somehow or the other, there is a reluctance to share the data. And secondly, that survey was never continued. It was never extended to the other parts of the country. Now we have seen it is no more an urban phenomenon. It is spreading into the rural areas. So the right thing for the government to do at this point of time is to have regular serosurveillance done periodically over the entire country and get the results and then share it with the people. I mean, I would like to go back to what happened in AIDS. We were reporting about 80,000 reported cases, like what we are doing today. But when we did a serosurveillance, sentinel surveillance, we found there are 3 million cases. But we could have just suppressed that and said, carry on. No, it was given. And initially, definitely, there is a lot of criticism, but we faced it ultimately. And I think that's how we came out of the denial mode at that time. I think somehow or the other, we still exist in a denial mode on prevention. It is a strong statement, but I would like to say that I think we are still existing in a denial mode without giving those figures up. How many Indians, what percentage of Indians today are having COVID virus in their bodies? This is a very, very important piece of information which is not available to us. The second is the government policy and testing. Now, testing is key. Right from the beginning, WHO has been telling us test, etc. But even in a scientific body like ICMR, there has been a lot of ambivalence initially about whether to test on a large scale or to limit the test only to the symptomatic cases. I think they opted for the second one. I think that didn't work well. And then over a period of time, you kept on revising the testing strategy, testing policies. I think it has been revised at least half a dozen times in the last 3-4 months. The latest was about 15 days back, I think it came out. But we should have done 1 million tests a day right in the beginning, right in April. But that 1 million figure came only in August, end of August or early September. Till that time, we were struggling with the numbers. So we have not really spread the testing network across the country, at least in the areas where there is high prevalence. And later on, even about the type of tests that you have to use, the test kits. Initially, they were all RT-PCR. Then they brought in the rapid kits without really seeing that what level of sensitivity and specificity is there for the test kits. Because unless a test kit has at least more than 90-95% sensitivity, I'm not a specialist, but I think many of you know that, it really doesn't serve any purpose. Today, we are deploying rapid test kits on a very large scale, knowing fully well that their specificity is only 70%. That means you can either end up with a false positive or a false negative. Now, what are you going to do with those results? Today, I can tell you, people are scared to go for a test, not only because of COVID, but because of getting a wrong result. No, this is really going against our testing policy. And I think sooner we come up with a good, reliable test kit for rapid, which has at least more than 90% sensitivity, I think our testing policy is going to fail. And we can't entirely depend on only RT-PCR for testing. So somewhere I think things have gone wrong in this. I think we still have not been able to correct it. The third important thing is, of course, we all know that, absolute lack of involvement of civil society. This is something I just don't know why this mental block of involving people, taking people into confidence, taking civil society into confidence, sharing data with them, bring them on board to both in prevention and treatment services, counseling services in hospitals. So many things could have been done. We have done it successfully. We have done it in AIDS. We have done it in polio eradication. There are many successful examples in India of very active involvement of civil society in epidemic control. But here we have not done that, especially for messaging like good quality masks, safe distancing, and then use of sanitizers. All these messages can't be just top down. They have to come up from the community. That has not happened. And look at Southeast Asia. Roy, you live in Thailand. Indonesia, the third largest country in this region, has just 260,000 cases. Out of them, only 50,000 are active cases. Same thing with Philippines. These are the two, I think, the countries with the largest amount of infections, which are just 250,000 to 300,000. And all the other Southeast Asian countries have less than 1,000 active cases. Why? After all, this virus is the same. It is the same COVID that we are having. But it's because of the responsible social behavior, because of the societal norms, because people wear masks even for a common cold, and people safe distances they keep. And whatever instructions have come, people have taken them very seriously because there has been a good amount of communication and taking people into confidence. It has not been a top-down approach, because of which I think people have been able to sort of get alerted to the threat, and today they are definitely enjoying the fruits of that. And we are suffering here. So I think that is one reason why, the third reason why I think we are not been able to really control the epidemic. But it's high time now. I mean, right now it's all over the place. It's no more restricted to only metropolitan cities. we still deny there is community transmission. Still we deny that there is a community transmission in the country. I don't know why. If you say that, yes, there is community transmission, nothing is going to happen. At least people will know that, yes, it is a serious thing. But somehow or the other, we have stopped sort of saying that. But it's high time. I think we need to take these 3 or 4 important public health measures to see that prevention comes back as a priority, and prevention becomes the key to our response to COVID in the months to come. Thank you very much.
Thank you so much for that. And yes, I would say that you are absolutely correct about Southeast Asia. Speaking from my own experience being here in Thailand this past 8-9 months, I can see that there was a strong focus on prevention right from the outset, and civil society has actually been the contributor to this. Say for example, in terms of the contact tracing, they have 1 million community volunteers who have been actually helping the public health, system. And these are people who have the trust of their friends, families, neighbors, cities. And so it's a whole of, it's a whole of society approach. And this is something that we haven't seen in India and of course, so many other countries where the epidemic has just spread out of control. So with that, let me turn back to my co-moderator, Mukta, for what we might call the meat of this webinar, at least the section from which the webinar gets its title, and that is the hackathon part of the session. So over to you.
Thank you, Roy. So I'm guessing that a lot of the participants understand the word hack. It's not just hacking into computers, but it's finding solutions and looking at innovation. And with that in mind, there was a hackathon from the 28th of August to the 30th of August that was organized by the Massachusetts Institute of Technology, looking at what could some of the solutions be for addressing COVID in India. And as part of this, there were different themes and different areas. There were 10 tracks, and people were invited over this period to think of solutions, to make a clear problem statement, and then come up with some of the answers that could work to address that. And 40 people were actually given, 40 teams and people were given awards of areas that were really, really useful and could be seen as solutions to address some of the problems that we deal with COVID. So please welcome our next speakers, Dr. Rao Mantri, as well as Kushal Gohil. So Dr. Rao Mantri is a pharmaceutical chemist. He's a big name in the pharmaceutical world. He's the vice president and head of drug product development at Bristol Myers Squibb and has more than 20 years of experience in the field of pharmaceutical sciences. He has a PhD in pharmaceutical chemistry from the University of Kansas, and he also specializes in chemical engineering. He's an alumni of the MIT Sloan School of Management, and he graduated in the class of 2020. So please welcome Dr. Rao Mantri. I'm also quickly going to introduce Kushal Gohil. Kushal is a pharmacist by training, and he leads corporate strategy and innovation at Parexel. He's also a graduate of the MIT Sloan School of Management 2020 class. So I'd like to invite you both to this session and tell us a little bit about the hackathon and say a little bit about what are the next steps. Where are we going from here? What do you see happening with this? Collectively, you have 15 minutes. And if I may invite Dr. Mantri to speak first, followed by Kushal. So over to you, Dr. Mantri.
Thank you, Mukta. I think we'll switch the order. So I'll let Kushal actually give a
Okay. Apologies. So Kushal, please, over to you.
Thank you, Mukta. So I think thank you for the platform. We are here for the second time. We came here before the hackathon, so wanted to give a quick update on how the hackathon went. So I'll cover the first part, and then Rao can speak about the next steps because we are actively working towards it. So at a very high level, as Mukta mentioned, hacking at MIT does not just mean coding, or it's not computer related. We use that term to define the process of ideation. So taking from ideas and creating like scalable solutions from it. So for the MIT India COVID-19 Challenge hackathon, which we branded as India Turning the Tide. We did it, although it was an MIT event, we did get a lot of participation. We had applications from over 60 countries, 31 Indian states and territories represented. Um, and we finally got around 3,700 participant applications, 470 plus mentor applications. And we partnered with around 100 organizations, all the way from Niti Aayog and Atal Innovation Mission to non-profits like the American India Foundation. Anyone who really wanted to help change this COVID pandemic. And as Dr. Rao mentioned earlier, we were really hoping that we can ignite the same level of passion at the grassroots level and not wait for the government to really, solve this for us collectively. Because Rao and like Rao Mantri and I, we are also part of a COVID alliance, and we did study what successful countries did in terms of eradicating or reducing the count. And countries like South Korea, for example, did a lot of the contact tracing app development on their own, right? Like it didn't come from the government. So it was a 3-day event. We started on a Friday. We had Mr. Sanjeev Mehta as our keynote speaker. He gave very good, anecdotes on how we can energize the informal economy. Um, and then on Friday, we split the 1,500 participants into a self-formation process where they aligned in a team of like 4 to 7 participants. And this happened on its own, like no pre-formed teams were allowed to join the competition. So people pitched their ideas, and then other folks who found that ideas interesting joined them and worked on the idea for the next 48 hours. On the second day, we kind of gave them some advice on how do you pitch, in a 3-minute window, like how do you succinctly give the message, how do you think about ideation. And we also were able to pull in a very cool panel that included Dr. Soumya Swaminathan, Chief Scientist at WHO. We had Mr. Pankaj Sahni from Medanta. He's the CEO there. And Ms. Shraddha Sharma from Your Story did the moderation of this panel, really to pull insights about, how can we think about the pandemic. And that's why I feel Dr. Rao's, comments were so to the point, because Dr. Pankaj Sahni or Mr. Pankaj Sahni had very similar feedback on we can't beat COVID if we are not kind of true to the reality about it. Like, there's no sugarcoating this issue. And the only way out of this mess is to be being truthful at all levels. And then on Saturday, the teams continued with their idea formation. And on Sunday, we asked all these teams to come in, present their ideas. There were a lot of coaching sessions available where they could reach out to the mentors for very specific feedback on their ideas, on how to pitch. And then on Sunday, we had this judging round. And I just want to clarify, like, the post-hack resources that we are creating and that Rao would explain, they are not just limited to the winning team. So even if you did not win, like in our books, everyone who participated is truly a winner. But we did go through the judging process, and we had 10 tracks. So I think I won't do justice to all 10 tracks because I was heavily engaged on one track from end to end. So just to give everyone an idea, the kind of ideas that came out on the track that I was in, a group of doctors who work in a government hospital came up with an idea of SIPI. So what they were trying to solve for is doctors are staying in their PPE gowns for 14, 16 hours, and dehydration is like a very big problem. So this team had a very simple solution where they put a sipping straw inside their PPE gowns, something that's available in all government hospitals. And by doing so, they were trying to eradicate this dehydration and the burnout issue that's happening in the government. And I thought the idea was so simple, but the judges panel really found this core to a big problem, even in our bigger private hospitals. The other idea, Asha Ki Kiran, was really trying to optimize the ASHA worker outreach. So they wanted to supercharge the ASHA network with some technology so they can really go after areas where you have the most problems. So people were really conscious about the infrastructure that exists and were trying to really build on it. The third team was trying to solve for, once the vaccine is available, how would we facilitate the safe delivery to everyone in the country? So as you know, in the US, there is a big government operation called Operation Warp Speed that is focused on doing this. So the government is working with the manufacturers, the CDMOs, in already like pre-planning for the vaccine distribution. So this team had like very unique ideas around this. So again, as I said, I can read off all these 40 teams and beyond, but just to give you a flavor, these ideas were very well thought of and they could be implemented very rapidly. So a couple of ideas are already in motion, like they've been implemented in some hospitals. But I think what we are trying to do from the organizing team point is creating this matchmaking portal where we can connect these teams to all the partners that have shown interest, from Mr. Ramanathan sir at AIM. Rati ma'am is on the call, like we spoke to her. So I think once we get a better idea of where the teams are, we'll be able to do that. But I'll hand it over to my friend and colleague Rao to explain this further.
Thanks, Kushal, and thank you for inviting us here and giving us a platform. I think Poornima University, Anilji had been great partners throughout this effort that we have put in place for the last month and a half or so. Just a couple of quick points. We are all organizing, all the members of the organizing committee are volunteers. And right from the outset, our goal was not to just run a hackathon where we were sort of crowdsourcing ideas on pressing problems related to COVID in India, but also facilitate a translation of these ideas into implementing on the ground. And happy to report that based on the engagement of the many teams that participated and the energy that they are showing, I think we are on our way in this journey and certainly committed to help them achieve these goals. As Kushal alluded, the next phase is really the role of matchmaking of these participant teams and partners. Immediately, we will send out, we are in the process of sending out a post-hack guide to all the participants, including not just the winners, but all the team members, which contains resources for the teams and essentially will be a go-to guide on the continuation of their projects. Subsequently, in the next few weeks, we'll be engaging with these teams to actually collect insights from them on the progress that they have made and the specific needs that they have on their journey. And this is actually very important because in the matchmaking process, it's essential for us to, as facilitators, to understand these insights before we start connecting them to the partners. Because ultimate goal is to really do this matching of partners based on their interest and strategic alignment. And obviously these teams are at different stages of from simple ideas to some of the mature ideas that are ready for implementation. The partners also are very varied, as Kushal pointed out. They are from nonprofits, academic institutes, government agencies, and obviously private sector as well. And based on the past experiences with other hackathons, the partners have strong indication that they would like us to play the role of these matchmakers. So that's what we are actually set out to do. And our ultimate goal is to see maybe at least 10 ideas coming out of this to fully scale up and actually become entities that solve most pressing problems emanating from this COVID pandemic, not just in India, but hopefully around the globe as well. So, that's where we are today, and happy to take any questions that you have. Thank you.
Thank you, Kushal. Thank you, Rao. I'm just a little bit confused. Rao's your first name?
Yeah, there can be a webinar on that. I'm a Telugu person, so I have a family name, which is Mantri, and then Rao is the last name, I suppose. And, there's an identity redundancy when it comes to me. So.
Okay. Thank you very much for that. I think we're going to continue with the theme, and I'm going to pass it on to my co-moderator, Roy, to hear a little bit about the experience of the hackathon from people who contributed to identifying the good ideas. So over back to you, Roy.
Exactly. So I know we're about 15, 20 minutes behind schedule, and I don't think we'll be able to catch up too much, but let's keep it focused and tight. So now we have the judges who are actually part of this wonderful process. And I've got the names of 1, 2, 3, 4, 5, 6 judges over here. I don't think we can hear from all of them. So why don't we focus on maybe 2 or 3? And let me start with Rati Godrej first. And then Rati, maybe after you speak, you can hand over to Dr. Arvind Mathur. So let me say a little bit about Dr. Rati Godrej. She is someone who has graduated from the UCLA School of Medicine in 1988. She did internal medicine from Cedars-Sinai in Los Angeles. She has also been in India, where she, of course, got married to my friend Nader Godrej. And she has been a consultant for the US consulate. She's done all sorts of other fantastic things, and she was part of the judging panel for the hackathon. And Dr. Arvind Mathur, who needs no introduction, he has been in public health, teaching clinical work, research for the last 44 years. He did his MBBS and MD from the SN Medical College in Jodhpur, and he has served in various posts with the Rajasthan government, ICMR. He was a consulting physician in Saudi Arabia, and so on and so forth. So why don't I start with you, Rati, and then you can hand it over to Arvind. And then if Anil, Jagdish, Naresh, and Narayan want to say anything else after that, they are more than welcome to, all in about 10 minutes. Over to you. Rati, over to you.
Yes, I'd like to say that it was very exciting to be part of this process, to see these young minds come together, trying to solve some of these very big problems which are confronting many countries throughout the world. They ranged all the way from how to solve some of the supply chain issues, as well as the manpower in terms of being able to have enough people to monitor the COVID situation, especially in highly dense populations. There was also quite a bit of emphasis on equipment and how to do resource allocation. And then, of course, many technical and technological solutions in terms of matching people who had COVID and getting them tested and seeing how they could contribute to possible plasma therapy. So many of these solutions came from very simple ideas which just needed the technical skills to be able to put them out to reach the hundreds of thousands of people affected. So it was very exciting, and certainly it was great to see the energy and enthusiasm of these young minds to try and solve these problems, which I think the government is struggling with, but possibly with collaboration with these young minds, we can come up with some good solutions. So thank you. It was an exciting project to be a part of, to be a judge for. Thank you.
Thank you so much, Rati.
Yes, please.
Arthur, over to you. Thank you.
Yeah, thank you. It was an exciting experience, as has been mentioned by Dr. Rati. Listening to very young, enthusiastic students and workers about trying to find out solutions out of box. And the area in which I was involved was a protection of the healthcare workers. That is an important area for all the healthcare workers to protect them from contracting infection. And it was heartening to see several new ideas coming out of the presentations which were made, like having evaluation, having a monitoring systems which could detect early on the chances of risk of developing contracting infection or so, or certain procedures to prevent infections also. For, as has been mentioned about modification of PPE kits, etc. So it was a very enlightening experience, I would say, because the participants came out with real new ideas. And when that gave this experience that when so many minds, bright minds, they come together, they can just try to find out solutions for any major issue or so. And that has been the objective of this hackathon, which has worked to find out a solution for this major problem which we are facing today. So it was a very good experience to be part of this hackathon. And I would say it was an educative event for me also. Thank you.
Thanks a lot, Arvind and Rati. I just have a very quick question, maybe Anita or one of the other judges. Will the results or will some sort of account of the hackathon be shared? Will it be posted online somewhere, or has it been?
I think Kushal or Mantri could answer that. But I just want to add one thing. It was a wonderful experience as a judge, and I was involved with Rati and Mr. Rao. And so I don't need to say much, but I think we at Jodhpur School of Public Health, we would take this forward, and we would love to work with MIT. And one thing I need to mention, they made us work very hard, all the judges. It felt like, in an emergency room, you're doing a CPR on a patient, like one after another. And we were like on our toes. We could not even get up for 3 or 4 hours. But it was a wonderful experience, and we would love to take this forward. But Rao or Kushal could answer your question, Roy.
Yeah, I've just posted the link to all the panelists, attendees. It's on our website. The winners have been posted there. And as you know, these teams succeed, we will be creating like more blog content to highlighting their progress along the way. So
thanks a lot. Perhaps we can share the link on the Facebook pages of JSPH and Poornima after this webinar, so that those who are watching, if they are keen, can actually access it. So with that, back to you, Mukta, for the next segment.
Thank you very much. So we're hearing about solutions, we're hearing about hacking, but in the first instance, solutions are at the local level. So I'd like to invite Ms. Bhavna Sati, who is a nutritionist by training, and she's the academic head at the Jodhpur School of Public Health. So Bhavna, tell us a little bit about how at the Jodhpur School of Public Health, you've been contributing to the COVID response. What has the community there been doing about COVID? Over to you. You have 7 minutes.
Oh, thanks a lot, Mukta. On behalf of JSPH family, I welcome all panelists and participants. Thank you so much for joining this program. Mukta, this JSPH family is a large family, and our students are major contributors as far as its performance are concerned. So more than 40 students of current ongoing batches are working 24/7 since the outbreak reported, and even some of them have not seen their family. They are fighting against this disease in different states of India and Afghanistan. One of our students, an epidemiologist, Dr. Suresh Chaudhary, I hope he must be in this participant list. Dr. Suresh, if you have been to this place, really that could have been a wonderful thing. But now I am representing you. He is an epidemiologist and a prime member of famous Bhilwara model team. This is a model known as for ruthless containment to stop coronavirus. Actually, who do not know about this, for them, Bhilwara is a district in Rajasthan who had early hotspot of COVID-19 outbreak in the first phase. And the public health team there responded with extraordinarily aggressive measures, which included imposing a curfew in the district, extensive screening, house-to-house survey to identify infected patients, then detailed contact tracing of each positive case. They took good care of community involvement in this campaign. And this model was further replicated in all over India. So our student, Dr. Suresh Chaudhary, proud of you. Second, some of the students in Karnataka, Chhattisgarh, Damandiv, Punjab, Himachal Pradesh, and other districts of Rajasthan are also working tirelessly. And guys, you are really proud of them. I remember my telephonic conversation with one of our students, Dr. Reshma from Bangalore, Karnataka, yesterday. Ma'am, I haven't seen my family for the last 6 months. Oh, that is the kind of dedication this JSPH community is giving to this community, this whole world, or I can say to their society. Proud of you guys. This side, our Afghani scholars, they are also going through same phase. Till this date, 7 students have been infected, cured, and now back to their workplace with same zeal and enthusiasm. So this is about our students, whatever they are doing. Next, secondly, various extensive webinars were done for academic accreditations for healthcare providers under the leadership of Dr. Anil Purohit. He is working day and night and bringing the best brains from all over the world to one platform, and that all should, so that all healthcare providers should get the best. This webinar is one of them, and Rati, Mukta, you all guys are now, you are the proof of that. I need not to elaborate all that, but yes, Dr. Anil, thank you so much. Thirdly, one is our telecounseling platform in its multilingual version is under development state, and with the help of our partner Indic-Chain, Mobilite, and Dr. Jagdish Hirsch is leading it. So he's also in this panel right now. Thanks again. Hopefully we would launch it early. And fourthly, but not lastly, our creative team led by Mr. Bhupesh Advani prepared wonderful audiovisual IC material for health education and promotion. It is well understood that without community involvement, our fight against the disease cannot be achieved. And also, as Jonathan mentioned in this panel, this fake news is also one of the big threats. These ICs can also handle the idiots. Idiots means the internet developed obstructive information threats. So what has Mr. Advani done? He has prepared very nice IC material, which is in a very easy language, catering different social groups, these ISA material were on prevention of this COVID-19 infection, like right hand washing technique, physical distancing, mask, etc. Even immunity booster diets, whatever should be taken in this time. But they were having very simple and local touch. During different phases of unlock, these creatives were guiding person with all do's and don'ts for example, for shopping, workplace, guest handling, etc. and etc. So this trip is actually is towards new normal is long. We are here to train more and more rightly trained public health workers brigade. So the journey is on. And I really thank you all guys because you are also part of that campaign done by JSPH. Thank you so much. Over to Mukta.
Thank you very much, Miss Sati. I really like what you said, that, you know, wherever you have to have a real response, the community has to be involved. The community has to be in the driving seat. And unfortunately, what we've seen in many parts of the world is a response led by law enforcement or the police. And I think, you know, again and again, we need to remind ourselves that that is not a model for success. A community-led response is the model for success. So thanks very much for that. And I join you in congratulating all of your students and faculty members who've been working on the ground and giving their time and their commitment to this. So with that, I'll hand it back over to you, Roy.
Sure, thanks a lot. So now we come to the final speaker, the final formal speaker before the rapporteurs will summarize the webinar. And last but not least, we have someone truly important in the fight against COVID. This is Madhav Joshi, who is the Chief Executive Officer at the India Health Fund. And if you haven't heard of it, I suggest you go and search for it online. They have a most impressive website, and they are an impact investment fund which has been set up by the Tata Trusts, which of course everyone knows of, and the Global Fund to fight AIDS, TB, and malaria, which of course everyone also knows about. And it combines these two forces through technological study, research, and Madhav himself has extensive experience in doing innovation design, and he has been also involved with healthcare, nutrition, consumer and corporate businesses, so on and so forth. So Madhav, I've been actually looking at your website, and I've been truly fascinated by what you are doing with COVID-19. So why don't you share that with us? Over to you.
Well, thank you, Roy, and thank you for the very kind introduction. So India Health Fund, as you mentioned, is an impact investment fund, where our focus is on supporting the development of solutions to improve outcomes in the diagnosis, treatment, and prevention of infectious diseases in particular, all of which leverage the latest advances in science and technology. And the Global Fund and Tata Trust came together to set up this organization because over time, infectious diseases have suffered from market failure, particularly when it comes to the development of new solutions. Over time, these have become diseases of the poor with inadequate returns to support commercial investment, along with long gestation periods and relatively low ability to pay for, sadly, many of the people who are afflicted by these. So there has not been a lot of new development in these areas, but they carry a significantly high disease burden as well as death rate. I think that's where the Global Fund and Tata Trust came together to leverage both the scientific knowledge in the country, as well as the very vibrant entrepreneurial ecosystem that we have. And India Health Fund really focuses on providing the capital that is needed for promising solutions which leverage developments in science and technology to go from prototype to market readiness stage and really develop the impact that they potentially can support, not just for India, but for other parts of the world. The organization is about 3 years old. Our initial focus was on supporting solutions for TB and malaria over the last couple of years. And that sort of made sense given the disease burden in India, as well as the very high death rate for both TB and malaria. So at the beginning of the year, India Health Fund was supporting a portfolio of solutions, all of which were leveraging either molecular diagnostics or artificial intelligence, data and analytics, or product design in some cases, to really deliver outcomes which were much better than what were available for diagnosis, treatment, and prevention of either TB or malaria. And COVID happened. And the question we asked ourselves was, as an organization that was mandated to support the development of solutions for infectious diseases, how could we play a role for the biggest public health issue driven by an infectious disease, where solutions were needed but not necessarily available? And the approach we've taken is really multifold. The first was to start with what we had at hand. And we asked the simple question, can what we were supporting be adapted to also be solved for COVID? And the answer, surprisingly, was yes. And Dr. Quick mentioned one of the many surprises that COVID has thrown up. This was the biggest surprise we got very early in the pandemic. So I'll give you a couple of examples. We were supporting the development of an RT-PCR-based test for TB, a battery-operated unit which gave test results in under an hour. Didn't need a trained technician to operate it or to really administer the test. And this had been validated at community health centers in UP and had received ICMR approval for tuberculosis and was being rolled out by the Central TB Division. Very early on in the pandemic, we asked the developers if they could adapt for COVID. They were very quick off the mark and were able to use the same platform that they had developed to develop a COVID assay, which, with the credibility that they had established and obviously the quality of the test, ICMR approval, and became the second Indian-made test to be approved by ICMR for COVID diagnosis. And this was back in April. The test costed 30 rupees versus the 4,500 that the other available tests were being were charging at the time. And this is the TrueNat test, which hopefully some people have now heard about, and currently being used in about over 700 labs and growing as we speak. But I think this is one example of how we've adapted. The other one was an AI-based tool, which was linked to a smartphone app, originally designed to scan a chest X-ray to diagnose TB. Again, meant for low resource settings, diagnostic centers where doctors weren't necessarily available, to reduce the time taken from diagnosis to initiation of treatment. This was also able to adapt their algorithm very quickly to diagnose lung damage consistent with COVID, and is now being used in hospitals in about 30 countries to triage patients, to identify those who need, with extensive lung damage, who need early access to a ventilator, which has been very useful, particularly in high demand situations. It has been a great example where many hospitals have used it. So I think where I'm going with this is at IHF, where we're now evolving is from disease-specific solutions to identifying platforms which leverage technology or science to deliver outcomes which can then be adapted across multiple diseases. And we have 6 in our pipeline that we are funding right now. And we are actively incubating another 8, which will over time become ready for deployment. And the rubber really hits the road when you're in deployment. It's not good enough to just develop something. So we're also developing implementation partnerships with various organizations to facilitate access to both the public and the private healthcare systems, so that all of these solutions have a faster pathway to market, so that they can really deliver the impact at scale that they were originally designed for, and that we, as part of our mandate, really seek to deliver. So that's a little bit about what we do and how we're adapting to COVID.
Thank you so much for that. I have a very quick question, even though we are running a little late, is how is the environment in India in terms of encouraging the work that you're doing? Is it getting easier to cut through, red tape and things? Are things moving faster now than they have in the past?
Well, thank you. So I'd say the environment is very receptive. And I think the one thing that COVID has done is that it's brought disease focus, and particularly in infectious diseases, to the top of everyone's consciousness. And I think that's facilitated it. The second thing that COVID has done is, I think it's catalyzed intent. And that intent is translated into action from stakeholders across the ecosystem. And I think that's to your point, where policymakers, as said, have now become much more open, much more aware of and receptive to the need for innovation, because they recognize that this is the only way we're going to really mitigate the impact of COVID. It's the same with, I think, developers who are really pushing the envelope. And I'm fascinated by, I think, both the quality as well as the creativity that we're now seeing. And the speed of action and turning around prototypes as well as development. I think an area where we are still working with the authorities, and I'd love to hear maybe some of the other panelists' views, is on regulatory approvals. And I think that's an area where we potentially can, I think, collaborate to be more effective and faster, so that many of these solutions see the light of day sooner rather than later. And I think the action around vaccines is a case in point that when there is a will, there certainly is a way without compromising safety. The last area where I do believe we still need to do more work as a country is in collaboration, because COVID is truly a global issue which has affected everybody in the same way. The solutions needed similarly need to be collaborative in nature. And I think the one area where we, and IHF is trying to play a more active role, is in collaboration, particularly for the aggregation of the resources that are needed, not just to mitigate the impact of COVID, but also to mitigate the impact COVID has had on other diseases. TB notifications are down 70%. We run the risk of losing all of the gains in malaria prevention that have happened in the last 5 years, only because of what's happened in the last 6 months. And this is going to need significantly more resources. The resources are available, but they're very fragmented right now. And I think that's the other role that India Health Fund is trying to play, which is to aggregate ideas, initiatives, as well as resources, so that the sum is bigger than the parts. So I don't know if that answers your question, but I think that's been our experience and our attempt.
No, thank you so much. This is so fascinating. And before we go to the rapporteurs, I have a request from one of the hackathon judges, who is also linked with JSPH, Dr. Jagdish Harsh, who is also the founder and CEO of Mobiloid, which is a telemedicine and other technical wizardry app and conglomerate organization. So Jagdish, you wanted to make some comments, please. Over to you.
Thanks, Roy. I actually missed, requesting Rao and Kushal, and now that I heard Madhav also. Mobiloid group of companies is deeply trenched into new technologies like blockchain, AI, IoT, and we offer our full support to all the parties who are into early stages of utilizing, these kind of technologies for digital health perspectives. And we'll be happy to contribute in a pro bono manner to all of them, if they could be systematically channelized to us, and also in our Okhla office in New Delhi, they can utilize our IoT lab for their experimentation and their own POCs, and bringing it to MVP level, which is minimum viable product level. And this is an open offer. We'll be happy to talk offline about it. Thank you so much. Thank you, Roy, for giving me this chance.
Sure. And now let me hand over to Anil and the rapporteurs, and maybe Anil, you can introduce the rapporteurs. Over to you.
Thank you, Roy. Mukta and Roy, I think you've done a wonderful job, and I know we did not go by the time, and I'm really sorry about that. But I think it was a wonderful panel. Narayan Prasada is a cardiologist by training. He runs a public health literacy organization, does wonderful work in public health, and he's at the Brigham and Women's Hospital in Boston with a joint appointment at Harvard Medical School. He's one of our reporters today. We partner in lots of projects and mostly on webinars, and we're exploring Latin America with him. So I would hand over to Narayana and also to Kandarp, my colleague at JSPH, who is a co-reporter. So over to you, Narayana.
Great. Thank you, Anil. Thank you so much. Listening to last close to 1 hour, 30 minutes, next time I just want to listen to all of you guys instead of me speaking, because you learn so much. One thing I learned is, considering we're all MD and MBBS guys, we try to use our risk reduction models using medicine. That's our brain set. Listening to you guys, I kind of realizing the public health risk reduction model should be based off social determinants, something that you have been talking about. And MIT COVID challenge made me see something very fascinating. I saw almost 70% of the people who are not even MD and MBBS guys. In fact, I saw someone with a high school kid. I saw someone presenting who was 14 years old. It was mind blowing how smart he was trying to give us the solution. Now, listening to the whole webinar, I made some notes. My apologies if I'm calling you by your first name, because that's the quick way I can do that. Jonathan spoke very eloquently on science, communication, and impact. He kind of spoke about facts and fake news, very nicely presented how we could sort that out. And he made a very good point I learned today, that deaths are actually, we are doing better compared to a lot of other pandemics. He showed a beautiful slide. And what he said was, we are doing very bad with economies, kind of distributed that into two pieces. Mr. Kapoor gave a very emotional personal journey. Being a physician and oncology surgeon, he spoke the value of spiritual practice, which we sometimes call in a Western word, integrative health, so-called integrative health, and how we kind of translated his loneliness to a solitude that healed him out of the emotional outbreak. I do want to know what kind of songs he used to listen back in days. Eventually, I hope you'll let me know. Naresh spoke about mental health. Almost 33% of the Indians are suffering from some degree of psychological issues. And his suggestion was not only personal, but also look at some of the structural variables. He kind of broke down that one, very fascinating. Monica, a pediatrician, she highlighted the value of intervening in child life course of a childhood, right from antenatal to all the way to the adolescence. And she highlighted the importance of nutrition. JVR Prasada Rao, very provocative thought process there. He discussed how we failed an opportunity we lost, especially during a lockdown. He kind of highlighted we had an opportunity to renovate how we could do things better, highlighting some of the failures in transparency, failures in disclosure, and he used a very good word, denial mode. It's a cool word I like to use in many of my personal experiences. And he talked about zero prevalence rate, how that rate has its own challenges. And most important thing, which I'm personally involved with, involving civil society in engaging pandemic management. Very excellent ideas there, sir. Kushal spoke a lot about his experience in MIT COVID, starting from ideation, linking into a scalable solutions, and he used another key thing that I liked about grassroots movement. Very interesting. And it was very nice to say the resources are available for not just the winners, for everyone who participated in MITs. Speaks highly of kind of work you guys are doing. Rao Mantri used, I'm just going to cite my eye-catching word, was matchmaking style of addressing the crisis. He kind of used, you need to think like a matchmaking, connecting the dots. Rati, Aravind, and Anil spoke about some of their experiences in MIT and gave a very nice narrative of their own personal experiences. Bhavna, a great tribute to all the graduates. You gave all you, that speaks highly of you again. You gave all your energy back to the students, and that's what most teachers should be doing. I'm proud of you for doing that. Madhav, collaboration, keyword. You need to keep collaborating all the time in order to go from prototyping to the next phase. That's the kind of summary I got. I do recognize I may not have captured all your ideas. I hand it over to my partner here. Thank you, guys.
Hello, everyone. It was very nice to hear from everyone. And I would like to disagree with Narayan, sir. He has summed up everything, what everyone has said. He has captured it very well. So there's not much I can say. And in the interest of time, I would like to take it forward to Anil sir and Jagdish sir.
Thank you so much, Narayan. It was very good summary, and thanks, Gandharp. I would give it to Ashish to close the webisode today. And thank you, all the panelists, the moderators, the rapporteurs. And I think without you, you would not be here today. So thanks again, and we hope to continue this partnership going forward. Over to you, Ashish.
Well, thank you so much, sir. It's really great honor and privilege to propose a vote of thanks today. And it's clear that we could spend more time discussing these issues, and that our speakers have a breadth and depth knowledge for that could enlighten us all. So let me extend the deepest thanks to our panelists. Great presentations, great discussions. And I wish that we could have continued on, but time doesn't allow. So let me also thank everyone, every panelist, JSPH, Poornima University, to sponsoring this webinar series, and thanks to all listeners for joining us today, for supporting this new modality of doing these kinds of panel. But I think it worked, and I was a little skeptical, but I think that we are finding new way of talking and a really important issues and coming together as a scientific community and the public to be able to ask, answer, and set of critical questions for our own health, the health of our communities, and ultimately our nation and the globe. So thank you all. Best wishes for our health and safety. Take care. And on behalf of JSPH and Poornima University Jaipur, I will thank all entire fraternity of this public health, and thank you so much.
Sir, may I please, can we have a group picture, and we can just, I just request all the participants, the panelists, to just turn on the camera. We'll just wave our hand and make this webinar memorable, and just capture a group picture of all of us, please. 3, 2, and here we go. 1. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you. Thank you.
Thank you.
Thank you. Thanks.
Bye.
Bye.